Hello and welcome to the lecture on consent. When we're thinking about angiography and we think about the trigger, there is an issue about whether the patients have had consent taken, and we must revisit the question about what is consent and how is this going to be relevant for angiographic procedures when we compare to some other examinations which we do in the radiology department. So if we revisit this central question for this lecture, what is consent? Well, we obviously think that consent is something that is given. We may think about that we consent to have an x-ray, or we consent to your attendance pattern being given to your clinical tutor. It's sort of a process of giving permission. But consent is a two-way process, because we maybe as radiographers will then eventually end up taking consent from a patient. So if we were going to do a line insertion for a patient that's maybe going to have some chemotherapy, there are radiographers who do this around the country, they maybe take consent from a patient. So they gain their position, the patient gives it, and we ask for their permission. So consent is a two-way process. But we often think with consent about there are different types. So how do you consent to have a tooth extracted in the dentist? How do you consent for your bank details to be given to a mortgage company? How do you consent if you're having a heart transplant? So there's a lot of different issues where consent may be given. How would you have consented for a procedure when you were 5 years old? How maybe would you consent for a procedure if you were unconscious due to a serious medical condition or maybe a road traffic accident? So consent covers a lot of pillars. So what I would like us to think of by the end of this talk is, how do we know when a patient's consented? And how do we know when we would have taken consent correctly? Because it's this two-way process. And if I was to say to you, lying on a table, we're about to put a stent in your iliac artery, sign this form, is that consent? Possibly you might say no or yes, but if it's no, well, why? What's not been satisfied there? So there are challenges in gaining consent. We know that there are obviously a whole raft of patients out there. Some of them are well, some of them are very unwell. So that can give challenges. We've obviously got age-related challenges about gaining consent for maybe a baby or a young child. We also have consent in later years of life when there may be cognition problems such as Alzheimer's. So there are lots of rafts about consent. What about if we're not able to sign? So if you can fully understand but you can't sign, maybe you've got quadriplegia. Again, how do you consent then? Do you need to be able to provide a certificate? So there's lots of challenges in consent. Who can take consent? Which patients can give consent? How do we know how long consent is valid? So 6 months ago you signed to say you're happy to have a heart transplant. There's been a donor heart come available. Is that consent valid from 6 months ago? People's opinions do change. So there are challenges. So if we start with the theory, what is consent? Consent, and there's some important words here. Consent is the voluntary, so that's the first thing, it has to be at your own will, and continuing permission of a competent, again another key word there, a competent patient to receive a particular treatment based on an adequate knowledge of the purpose, nature and likely risks of the treatment, including the likelihood of its success and any alternatives. Now that is a massive statement, but actually you can break the entire consent process up there by just homing in on this paragraph. So if we look, it must be voluntary. That's easy, we don't have anyone's arm up the back, or we don't, if it was consent maybe for a child, we'd be telling the child you've got to have this done. So it's got to be voluntary, it's got to be continuing, and that's the point about if you consented something 6 months ago, would it still be valid now? You have to understand that the patient is still giving their permission. They've got to be competent. Now that can be difficult. How do we know whether a patient's competent? They've got to have adequate knowledge of the purpose. So why are you doing this? What actually does it involve? The nature, and the patient's got to have understood the likely risks of the treatment. including its success. So what are the risks, but what are the chances of this working? And you have to give the patient alternative. Now often that doesn't happen. Say you're having a DHS to repair a hip fracture. It's a very successful operation, but there are risks of things like the DHS could fail, you could get a post-operative infection, a DVT, a pulmonary embolus, you could die, you could get some bleeding. But do we tell them what the alternatives are? So again, fitting all this into the umbrella of consent is a challenge. So medical consent, what is this? Because we get people to consent to release financial data, but what's medical consent? Well, if we just take this back a little bit, the early idea really followed about the need for medical consent followed really the World War II and the Nuremberg Code, and that's basically when the German Nazi regime put a whole raft of medical experiments on prisoners of war, and largely they didn't ask them for permission. They just thought, well, try this new medicine, try this new technique, try this new treatment, and there was no consent at all. And if we hear about people who had surgery without any anaesthetics, and lots of horror stories regarding twins and various atrocities. So following that, said that if you want to do anything to patients or people, it's got to be voluntary and it's got to be informed. So you've got to be able to give permission and their free will, and they have to understand what's going on, not just take this blue tablet and you'll be okay. So why is consent necessary? Well, if you think about how we human rights nowadays, patients have a fundamental legal and ethical right to determine what happens. We own ourselves, so if something's going to happen to us, legally we should have some say. And I suppose ethics, it's our body, you're in charge of yourself. If you don't want something, you're right. Nobody should force something on them. So the purpose of consent stems from the fact that in many instances the cooperation of the patient and the patient's faith, or at least the confidence in the efficacy of the treatment, is a major factor in contributing to the treatment success. What that means is if we just were to write, in the UK, we're not going to ask you to do anything, we're just going to do it. Actually, the patient needs to believe in the treatment for it to work. And a lot of people believe that there's a psychology around getting better. That patient really has to be on board with that treatment for it to work. You think about a heart transplant. Heart transplant is not just a surgical procedure, it's a life change in terms of the drugs that are going to stop the body rejecting the transplant, staying healthy in order to maintain the best chances of surviving for as long as possible. So you've got to have the patient on board. If the patient's not interested in doing it, the transplant's likely to fail. So, consent's necessary because you've got to have a patient with you for the treatment. It's no good fighting and saying we're going to try and treat this patient against their will. So consent in medicine, as we know, there's a duty really to obtain consent for the purpose of diagnosis, treatment, organ transplantation, research, pretty much anything within medicine where we're going to do something with patient or their records, we need to have consent. And you might think, well, how do we do that in diagnosis, or how do we do this in research? The whole raft, and we see things like patients signing consent forms, people getting organ donor cards, people getting asked whether they can allow their medical records, say, to go to a solicitor if they've been involved in a road traffic accident. So we can see consent all around us. For diagnosis, we see the patient consenting, they come into our x-ray rooms, they lie on the table, they put their hand on the detector. They consent in a slightly different way than we would imagine for open heart surgery, but we can see elements of consent on us. So consent, because it's so important, there's guidelines all across the world from various bodies, and obviously in the NHS we live largely under the Department of Health, and they really give guidance on consent, and they say the seeking and giving of consent is usually a process rather than a one-off event. So consent's continual. It's not I've got a consent form in my back pocket, so therefore we're fine to do whatever we want to that patient or whatever's on the form. For major interventions, it's good practice where possible to seek the person's consent to the proposed procedure well in advance. So that's why you often see consent being done in outpatient clinics, not in the anaesthetic room prior to theatre. When there is time to respond to the person's questions and provide adequate information. So the patient can hear about the procedure, they can ask questions, they can get information, and they can go away and digest that. In that anaesthetic room, and you've got a syringe full of drugs to put the patient to sleep, it isn't the right time. Clinicians should then check before the procedure starts that the person still consents. If a person is not asked to signify their consent until just before the procedure is due to start, at a time when they may be feeling particularly vulnerable, there may be real doubt as to the validity. So that's almost, if you think, well, we won't bother seeing patients in the outpatient clinic, we'll just get them in and we'll just lie them down, ask them to sign just before we start that angioplasty procedure. They may be thinking, well, I don't want to waste people's time. Can't feel I can say no. They're vulnerable. You're in a hospital gown. You've got people around you. You could be perceived as being coerced. So a lot of people believe that consent in that form isn't consent because the patient is probably going, potentially could be going against their own will. Furthermore, the Department of Health says in no circumstances should a person be given a routine preoperative medication before being asked for their consent to proceed with treatment. Well, if you think about a pre-med is a sedative. It's to relax the patient, it's to make them feel relaxed. Well, sometimes having nerves, having anxiety might be a reason to ask, can the procedure be delayed? Can I have more information, other alternatives? So to take that away is effectively removing the voluntary choice of the patient. So the Department of Health Informed Consent Guidance, this is what they say should happen. Patients, when the consent's been taken, should be introduced to the person. So you're a doctor, you're a surgeon, you're a radiographer, and explain why you're there. So if it's a line person, introduce themselves. So the name, they're an advanced practitioner in radiography, and they're here because you've been asked to put a line in and you're the person going to be doing the procedure. You obviously do an identity check to make sure, and you've got to use plain language and avoid medical jargon. And there's good guidance if you think about the British Heart Foundation with heart surgery, produce good plain English guides about how you can consent patients for coronary artery bypass grafts, because often patients think, I don't understand what I'm actually having done. It's a technical language. Within this, you've got to discuss, so it's not really stating, it has to be a discussion. What is the nature of the procedure? So it's open heart surgery to bypass a blocked vessel with the intention of removing the patient's signs and symptoms of angina. The risk could be that heart attack, death, bleeding, but the benefits is that patients should be able to pursue a more active lifestyle, get less pain, and be less at risk of a heart attack. The alternatives could be an angioplasty. However, maybe data's shown that it's unlikely to work for such severe disease, and you have to tell the patient, a little bit like if you've been involved in any research, you understand that you're choosing to have this operation. You could refuse, however, you could have a serious heart attack if you don't have this done. Do you understand everything that I've said? And then would you be happy to move forward and sign the consent form? So there has to be documentation. So the documentation, again, this is important because this consent is a process. So consent forms a visual, a written record, but not just the patient's signature, but also really to summarise the fact that this consent process has been acted. So a signature to sign by the person taking the consent to say the conversations took place. A signature by the patient to again indicate that there was a consent process and that they're happy and they have the chance to answer questions. It must be dated and timed, and it's only valid, or the guidance is it's only valid for 90 days. So again, often your outpatient appointment and duration must coincide, or patients may be brought back into the clinic to get consent again. And again, often people will summarise the conversation. So what was discussed, the risks, what are the risks? 1 in 1,000? So there are various types in consent, and again we see these in our practice but also in daily life. Informed consent, express consent, implied consent, surrogate consent, and advanced consent. And we'll talk about these in a second. And again, there is some overlap, and again there's some debate about whether there are perhaps less variants. So informed consent is the voluntary acceptance after full understanding. So we give information, the patient is then informed, and they make a decision voluntarily whether to have the done. So for instance, if they're having an angioplasty, they get all the information, intended benefits, risk, and then they decide whether to go ahead, and that's informed consent. But there's obviously some prerequisites. The patient must be able to understand the information that's being given. So the problem is potentially you could have a conversation, say, with a patient that's got, say, some learning difficulties. You could have a conversation, you could ask them whether they want it done, they could say yes, but are they competent to understand? That has to be tested. You've got to give them adequate disclosure of the care plan, so again, what you're fully planning to do. So you may say the operation, but actually the result of the operation you have to go on to some, you may need a blood transfusion, which they're happy with the operation but not the blood transfusion, so it needs to be full disclosure, risks and benefits, alternatives, and it's got to be free from coercion or manipulation. And what do I mean by that? Well, imagine if the relatives were there and it was a heart transplant, the patient said they didn't want it, they felt it was enough, they'd been a long journey through treatment. But the relatives know you must have it done, you're not being fair, there's unfair sort of family pressure. Or imagine it's a new treatment and a surgeon's trying to get a particular reputation. They were like, you must have it done, I'm telling you must have it done. If you don't have it done, I won't be able to offer you at a later point. So, unfair coercion and manipulation. It must be person and procedure specific, so you can't really have a pre-printed consent form, say for an appendix removal. You've got to look at the patient in front of you and the procedure you're going to do and take all of these into account. Expressed consent is when a person says, I want you to do this, or in writing has more weight. So, I give you permission to remove my tooth, or you ask them, can I remove your tooth? Yes. So again, a lot of this is what we see in radiology, or if we're in a doctor's surgery and there's a need to do an intimate examination, such an examination of the rectum, then the doctor will explain, I need to do this, but as part of the problem that you're presented with, are you happy with me to do so? And you can give oral consent. And again, it can be written. Implied consent is where we don't actually ask necessarily a patient, are you consenting to this chest x-ray? By the fact the patient's turned up at the hospital for their appointment, they've gone into a cubicle and have got changed and they've obeyed our instructions, and when we said you're here for a chest x-ray, is that correct? They've agreed. So it's implied by their actions, and again it's for very low risk kind of, I suppose, low duress exams. It can be for some treatments. Imagine like physiotherapy, where you're turning up, you may be removing your shirt to have your shoulder manipulated. It's implied. It's things where the risk of complications is exceedingly low. Surrogate consent is consent given by a family member for minors or deceased. We've got to be very careful when we move into the idea of, say, an adult patient that can't consent. Is it actually consent, or are we doing something slightly different? But consent can be given by a family member for minors or the deceased. Generally, there is a hierarchy to consent, which the patient really is the first one we go to when possible, apart from if the patient can't understand, so in the young child, or can't relay an answer in the cases of a decease. If not, then we go to the family, and failing that, if there's a reason why maybe the family can't, or the family's views go against maybe best medical care, or the family disagree, and it's two sides of a family, then it would go to the court. Advanced or proxy consent is given by the person in advance before the death. So we hear about these, about living wills or advanced directives. So, for instance, if I had an accident and ended up on a life support, I give consent for it to be turned off. I withhold consent from any cardiopulmonary resuscitation in the event that I go unconscious. So sort of advanced consent. I withhold consent to have a blood transfusion. Proxy consent is consent given by an authorised person, so you're acting on that person's behalf. So this could be two doctors in an emergency setting, so two doctors can sign. There is some belief that people can be proxy consent if you have you give power of attorney to somebody that they can sort of consent on behalf. So if you think about the ethical challenges now. So what happens if you've got somebody that's incapacitated? So there maybe are they drunk, are they unconscious, or are they an incompetent patient? So maybe they've got severe learning difficulties, things like autism, where actually there's going to be an issue. So what happens there? Well, is there an advance directive? Is there anything written that if the person was to become incapacitated, there is an indication of what they would want? If not, then you can go to the legal next of kin. Now, what you're not doing there necessarily is getting consent. You're trying to do your best to find out what the patient would want in that circumstance. If there's time, so if you imagine somebody with Alzheimer's and they needed, I don't know, a tooth removed, or they needed to have a minor surgical procedure where there's time, there is a process where you could go through the courts to get somebody established as that guardian, or getting power of attorney, but that depends on whether the procedure is urgent. The basic understanding is that if doctors, when doing procedures, would be asked to justify they were acting in the best interest of the patient. So if it was urgent, somebody had collapsed, they were unconscious, and there was no evidence to say they didn't want the procedure and it was felt to be life-saving, you acted in the best interest of the patient. If it's something can be delayed, then again these processes need to be considered carefully. What about treatment refusal? So the patient, I don't know, has a road traffic accident, they get run over and they've got extensive bleeding within the abdomen. But they're wide awake, they're in resus, and they say, I don't want an operation. But the doctors say, if you don't have an operation, you're going to bleed to death. The law says that competent patients have the right to refuse treatment. So if you can deduce that the patient is competent, is they understand what's happened to them, they understand the treatment being offered, and they understand the risks of not having it, then competent patients have the right to refuse, even though it sounds like it's a totally stupid thing to do. What would happen in that situation? You'd get colleagues to confirm the patient's capacity to understand. You wouldn't check, you say on your own, well, I've checked, they can count to 10, they know who the Prime Minister is, they've told me that they understand. You'd want to get it checked from a colleague. And really, if it was something that serious, you'd want to get psychiatric input, because again, are they doing it because they're they are unwell from a mental capacity? And if there was time, you'd maybe want to consider an ethics committee. So not a research ethics committee, just an ethics committee, to see whether it's ethically sound what the patient wants to do, or would it be ethically sound to go against their wishes. What happens if there's a language barrier? Well, language barriers are no excuse for just consenting on a patient's behalf. You've got to use an interpreter, and hospitals have a list of staff members that can speak different languages, and they also have a phone service, so you phone a number, you can get put through to a medical interpreter, so pretty much any language. You give the patient another phone, you have a phone, and you can have a conversation between the two. If it's something complex and something that can be planned, generally you book an interpreter to attend the outpatient clinic or on the ward. Patients can refuse an interpreter. You can use family members, but really you need to be very careful about that because of the element of coercion. How do you know that that person's truly explained what's being said in the native language? Consent for minors. How does this happen? Parents must legally consent for their children under the age of 18. Now, that sounds a bit, if you're 16 and you're having an operation, the law says parents must legally consent. However, there's this issue of assent. So it's almost consent really is a dual process. You have to have the parents on board, but you have to have the child on board. And that can work in the opposite direction. If a child wants something and the parents don't. And this is this thing called Gillick competence. And this was a landmark course case where the courts tested whether the child had capacity. And in that situation, there can be instances when a child can consent. But ideally, the parents must consent on the child's behalf. But if you see a child, so they're in 14, 15, there will be a dual process there that the child has to agree, but the parents will do the signing. So this slide really talks about how Gillick competency and Fraser guidelines. So these were landmark cases that went to the High Court about whether whether a child can consent depending on their maturity and understanding. And I won't read this out, you can just pause there and read the decision. So there are some ethical dilemmas about sometimes these situations when patients aren't told the truth, and therefore how can you really give informed consent? Maybe if it's somebody that's particularly frail and they've got cancer and you need to put a line in to give chemotherapy, and if they don't, ultimately they'll succumb to cancer. Maybe you've not give that level of information, but the question is, can consent ever be fully informed unless you give full disclosure? And I think there's lots of literature coming out about this duty of candour, which is a duty to be honest to patients. You can't make a decision about what to tell them and what not to. End of life decisions, again about a patient's, I suppose, the patient's mental perspective when they've got to make an end of life decision. Again, can they make an informed judgment? Advance directives, again, advance directives are fine when patients are well and they're thinking, if this was to happen, this would be my wish, but would that have changed if they were in that predicament? Advanced directives are quite topical when it comes to euthanasia. Patients with maybe neurodegenerative conditions such as motor neurone make a decision about end of life, but they want it when the disease reaches a certain stage where they wouldn't be able to consent for themselves. But the question is, how do you know that patient may not have changed? Being at that stage may not be as bad as they thought, and actually they'd like to live a few more months or years longer. And obviously emergency consent, if patient arrives, the family said they wouldn't want an operation, how do you know that that's true? How is that managed? So the last slide really is to just focus on about angiography, because this is the focus of the trigger. Why do we not get written consent for somebody having a chest x-ray or a CT scan, but we get written consent for somebody having an angiogram, which is possibly in an adjacent room? Well, angiography has risks, and it's a treatment. So there is a risk-benefit discussion with a patient. So the benefits need to be, and sometimes the benefits are uncertain. We know that angioplasty or stenting doesn't work for every patient, and it only works usually for a period of time. And there are significant risks, not just risks theoretical, risks, bleeding, pain, infection, that may keep a patient in hospital longer, may make the patient unwell, and may even require an operation. So the risks are significant, and the risks are in the order that patients may decide not to accept them. So for angiography, consent must be informed. There needs to be this discussion. It needs to be done prior, and that's difficult in radiology because we often don't have outpatient clinics. We often sometimes get patients just sent to us from other doctors within the hospital. So how can this be managed? So often we see that they have what they call radiology clinics, where a patient may come to the radiology department, have the discussion, sign the consent, and then they may come back several weeks later. And ultimately, they've got to have capacity. Now, I'll just finish with a very short story. When I worked at a hospital in Manchester, we did a lot of interventional procedures. So a lot of procedures using fluoroscopy to treat patients. And these patients came in the day before. They were admitted to the ward. Obviously, they got changed into hospital gowns. They had some blood tests, and then the next day they came down and had the procedure. And the procedure did have risks. It was painful, so they were sedated. There's risk from sedation, and they could have got quite a strong infection of the stomach, and that could have kept them in hospital. It could have potentially, for some patients, put them on intensive care. Now, what the hospital decided to do as a piece of research was to get somebody to go to the ward the day before, explain the procedure on the ward, answer any questions, and leave them a patient information leaflet. And if they were happy, they signed the consent form. And that was taken by a specialist nurse. So a nurse who worked in radiology, who was involved heavily in these procedures. And what they did at the same time is they gave them a small test, and it's called a mini-mental test. And it's basic things like who's the Prime Minister, what day of the week it is. And it's about 10 items, just really ideally to test capacity. And pretty much, you imagine in the radiology department, most patients pass that. So what they did then is they went back to the patient a couple of hours later, and they asked them a number of questions about the procedure they were having the next day. And they decided that there were so many questions the patient needed to get right in order to consent to be established. What was the name of the procedure? What did it involve? What were the benefits and what were the risks? And then they did the same the next day. The minute the patient arrived in the radiology department, just before they were going in the room, they asked them the same questions. And what they found is that over half the patients wouldn't have satisfied the criteria of consent within 24 hours after having consent. So you think most places leave it longer. So that's why there was this issue about how best can we deliver consent, because if we really apply the guidelines, there could be many people that are having procedures done where consent isn't still active. So consent for angiography, just to finish, is because it has serious risks when compared to standard diagnostic tests that we use. There is some debate creeping in about things like contrast reactions, should we get consent for that, even radiation induced cancers. We think some of the exams that use more radiation, maybe on children. So we'll have to see how that develops over future years.